Microsatellite instability has been in the news recently with two particularly impactful, one publication and one presentation. In gastroesophageal cancer, MSI-high tumors account for approximately 5% of cases. It's slightly lower than that in metastatic disease, though slightly higher in locally advanced disease. And it's also more common and enriched in gastric tumors compared to gastroesophageal junction or distal esophageal tumors. Now, for locally advanced disease, until recently, the standard of care was surgery. And this was from a meta-analysis led by Dr. Pietrantonio that showed that perioperative chemotherapy was actually detrimental in these patients. And that's since MSI-high tumors are not sensitive to chemotherapy. We've learned, though, however, that they are exquisitely sensitive to immune checkpoint inhibition. And since then, there have been two phase 2 studies, the Infinity trial and the NeoNuPigo trial, that showed that neoadjuvant dual PD-1 and CTLA-4 inhibition in locally advanced disease led to pathologic complete response rates of 60% and major response rates of 80%, far above the historical control that had been around 10 to 15% with perioperative chemotherapy. And so now in the NCCN guidelines, it's actually recommended for dual PD-1 CTLA-4 inhibition for patients with locally advanced MSI-high gastroesophageal tumors. Now, slightly tangential to that, nearly 3 years ago at ASCO in 2022, the plenary session with a simultaneous publication in the New England Journal of Medicine, neoadjuvant PD-1 inhibitor dostarlimab in patients with MSI-high rectal cancer demonstrated a 100% complete response rate. Just last week in New England Journal, there was an update of this study that showed of the 49 patients with mismatch repair deficient rectal cancer, all 49 had achieved a clinical complete response rate. This study also opened a second cohort, which is appropriately described as cohort number 2. And in this publication, they detail the patients included in that, but it includes non-rectal cancer MMRD tumors. And so these patients were evaluated with 6 months of neoadjuvant dostarlimab. And from among these 54 patients, 21 had either gastric or esophageal cancer. And again, as we talked about, the majority of these were gastric. 65% of the non-rectal cancer MMRD patients had achieved a clinical complete response. 57% of the gastric tumors had a clinical complete response. Of the 6 esophageal or GE junction tumors, it was only one of the 6 who had a clinical complete response, whereas the other 5 had an incomplete response. So certainly still remarkable outcomes compared to what historical controls have been, but not at the 100% mark that we saw with the rectal cancer cohort. Also last week was AACR, and there was another investigator-initiated study that evaluated PD-1 inhibition in locally advanced MMRD tumors. This study looked at patients who had completed all standard of care therapy upfront, and then on screening testing had detectable circulating tumor DNA, which from the wealth of data that we've seen is a poor prognostic biomarker and shows that patients are at very high risk of recurrence. So more than 170 patients were screened, 20 of whom were found to have detectable circulating tumor DNA within that 6 to 10 week window. 6 of those patients had disease progression in the time between their screening test that identified a positive circulating tumor DNA test and prior to starting adjuvant pembrolizumab. So these patients were the clinical trial evaluated 6 months of adjuvant pembrolizumab, and 6 of these patients had already found to have disease recurrence and stage 4 metastatic disease prior to starting any adjuvant therapy. 13 patients were started and completed adjuvant pembrolizumab. 6 of these 13 had gastric or esophageal cancer, the majority of whom had gastric cancer. So of the 13 patients, 11 or 85% had clearance of their ctDNA, and with a median follow-up of 32 months, so nearly 3 years, 8 or 73% were still relapse-free, had not had any recurrence of their disease. Looking at each of these three cohorts together, 2-year overall survival was 98% in the ctDNA negative cohort, so those who were screened but screened out of the trial because they had undetectable ctDNA. So again, reinforcing that this is a favorable prognostic sign. In the ctDNA positive group, who then went on to receive adjuvant pembrolizumab, 92%. The 2-year overall survival rate was 92%, whereas in the ctDNA positive group, who recurred prior to receiving adjuvant pembrolizumab, the 2-year overall survival rate was 67%. So looking at these two studies that evaluated PD-1 inhibition in patients with MSI-high tumors in the locally advanced setting, I think there are a couple of big picture takeaways here. So first is that these tumors remain very sensitive to immune checkpoint inhibition, and really seemingly even more so at earlier stages of disease than once the disease has already become metastatic. And I think another takeaway from these two studies, which were tumor agnostic, is that not all mismatch repair deficient tumors are created equal. And certainly we saw that in the rectal cancer compared to the non-rectal cancer cohort, that there is still that while MSI-high tumors are favorable relative to their MSS counterpart, they still retain some differing biology owing to their site of origin. And both studies also added to the growing wealth of data regarding the role of ctDNA and the role ctDNA can play in helping to guide our treatment strategies.